Bonjour tout le monde. Hi everyone. Thank you so much for being here. This is the second to last conference of the Montreal Health Ethics Seminar Series. So we have one conference coming up after this one on May 23rd. It's a conference by Amy Harbin from Oakland University. So as always, all of the information about the upcoming conferences is on our website and on our Twitter page. So today we are welcoming Annie Pullen-Sansfaçon. She holds a PhD in ethics and social work and has been interested in anti-oppressive approaches and ethics since, I think, the beginning of her career. The work that she will be presenting today reflects her strong commitment to understanding the experiences of oppression and resistance faced by trans youth and their families. And her implication with this community and the issues that they face is nothing short of remarkable. She is the co-founder of the organization Gender Creative Kids Canada. She has published extensively on effective intervention and developed projects aimed at furthering our understanding of oppressed and marginalized groups, and has played an important role in the National Assembly's adoption of Bill 103 in 2016, which is a bill that, or legislation that reinforces attempts to, or efforts to eliminate transphobia and improve the lives of transgender children. So we are really deeply honored to have her as our speaker and present as part of this series. I think it's really connected to the themes that we've been trying to put forward. Her talk today is titled, "What is Our Responsibility with Regard to the Care of Transgender Youth? An Exploration of Recent Evidence about the Lived Experience of Gender Diverse and Trans Children and Youth in Clinical Care." So please join me in welcoming her for this talk.
Hello, everyone. Thank you very much for that great introduction. I'm humbled to be here today with you. So as Corinne explained, I'm going to talk a little bit about trans youth. And the way I'm going to do that is that we're going to start looking at basic concept and knowledge, because I think if we want to be understanding what's our responsibility, we need to make sure we understand what it is, a trans person, a trans youth, and their context. Then I'm going to move into looking at emerging result of a study that is still underway. It's a study which is national. We've got 3 sites, one in Montreal, one in Ottawa, and one in Winnipeg. And we're looking at basically the experience of trans youth who are accessing gender-affirming care. So I'll explain you what it is, but basically it's youth who require, for example, hormone blockers or hormones or further surgery later to be able to live their authentic gender self. And then I'm going to conclude by a short discussion on, what the emerging evidence on trans youth, where it can bring us in terms of like moral responsibility. So if we talk about trans youth, I think one of the first things is that we need to understand that sex is not the same thing than gender identity, and it's not the same thing than gender expression, and it's not the same thing than sexual orientation. And unfortunately, this is one of the common mistakes, is that people kind of put everything together. So just very rapidly, when we talk about sex, we talk about a medical, biological, medical legal category, okay? And why I'm saying that is that the first part is that it's biological, it's medical, because when a baby is born, we do an exam, we look at genitals, external genitals, and then we assign a sex, okay? And it's legal because that assignment is going to follow you all your life on your ID, okay? So we can't see sex as just something biological, okay? It's got really kind of a effect that are much further than that. Then gender identity is different from the sex. It's a profound personal experience. So, I mean, everyone has got a gender identity and everyone's got an identity, okay? So when we think about gender identity, think about your own gender self and how you feel about yourself. And this is what gender identity is, yeah? So basically, it's how we feel about ourselves. It's deeply personal, and it can correspond or not to the sex assigned at birth. So there's people who feel that they are congruent with their identity and their sex assigned at birth, and there's other people who don't feel that it's quite matching. So as you can see, it's a little bit low, but I've put a citation from Diana Renshaw, who say that our core gender identity lies not between our legs, but between our ears. It's the message that sends our brain, okay? So it's very different, you see, from sex. And so whether the child is trans or non-cisgender, cisgender is the opposite of trans. So a cisgender child would be a child that's got a gender identity that is congruent with the stereotypical kind of expectation for the sex assigned at birth, or gender diverse. You must remember that it's only the child, the person that can really assert, affirm, and confirm that identity. If I was trying to kind of say, your identity is this, you would probably feel like really bad. You would feel like not recognized for who you are. So when we talk about identity, it's really important to know that only the person can discover it for themselves and then affirm it to others. Ah, I did a mistake. There you go. Then we've got gender expression. I'm going to move fast onto that, but gender expression is the way we express our gender to others. What's important to know is that sometimes our gender expression is not the same than our gender identity, because it's possible that basically there's constraints around us that make us not being able to basically express it. Okay? So we need to just remember that, and then when we talk about sexual orientation, is the physical or emotional attraction towards other people. And basically, cis people, trans people, everybody's got like a sexual orientation, and it's not linked to our gender identity. Does it make sense? Okay. So when we talk about trans youth and gender diverse children, we talk about children and youth, young people who identify differently from the sex assigned at birth. And I say differently because it's important that we don't see it as something binary. So there's people who will feel like male, there's people who will feel female, but there's people who will feel all, you know, it's like a spectrum, so you can feel like about anywhere on that spectrum. So we don't want to erase and forget about non-binary people. Okay, so when I'm talking about trans youth, I'm talking about everyone who identify basically differently from the sex assigned at birth. And they've been present in many cultures and times. I think we need to remember that. We always say, oh, it's new, you know, new trend. It's not new. I mean, trans kids, trans people have been there, you know, across different culture. I mean, if you look like into indigenous people, you know, there's really very big evidence of two-spirit people who have been existed, and actually they were celebrated and having often like some important social role in communities. So yeah. People often ask, how many are they? It's very difficult. I mean, these statistics are probably very conservative, because to come to those statistics, you need to want to take on the questionnaire that you identify otherwise. But I mean, it looks like it's going from 0.7 to 1.8. Okay, percent, and these are statistics for young people. So they are statistics from 13 to 17 years old. Okay, and the most recent is the one from the Center for Prevention and Control of Disease, 2019, and it's the 1.8. So it seems to be increasing in terms of percentage. So probably people are feeling a bit more comfortable to assert their gender on that sort of thing. But you know, probably there's more people than those statistics. And the last thing I would say on, you know, those trans youth is that we must not forget that they are a very diverse population. If we look at news, if we look at media, we often see the same sort of young trans person. They are white, they are middle class, they are accompanied by their parents. But we must remember that a lot of trans youth are, you know, not having the support from their parents. They might come from different culture. There's a lot of disabilities. A lot of young people got disabilities. So when I'm going to present you their experience, we must understand that this experience might be worse or better for some young people, depending where they are located. And I think it's really, really important to have like some sort of like intersectional analysis of what we're seeing here, because it's not the same for everyone, okay? So here you go. So I don't know if you know about gender identity development in children. I'm not from psychology, so I'm just going to go very, very quick on that. But I think it's important to realize that gender identity in everybody develop around 2-3 years old of age. Okay, it tends to kind of become a little bit more stabilized around 5-6 years old, but it really starts developing around 2-3 years old. So it's not surprising to have like 3 years old saying, "Mom, I'm a girl," when you thought for 3 years that they were a boy. Okay, it's because it's developing really early on. Then we must also remember that not every young people will know it from an early age. Okay, that's another thing that we need to debunk, because some people will assert their identity at the age of 30, some other people will assert their identity at the age of 13, and so it's okay. Because, I mean, if you just look at these statistics from a Clark study, which is an Australian study, out of like the 1.2% of their 8,000 young people who said that they were trans, there's like about 30% of them who knew it before the age of 8. But you see there's like more than 50% who didn't. Okay? So it's really important to know that, you know, it might happen and that gender identity development is complex and dynamic. It's not just something that, you know, I mean, I just said like 5 minutes ago that only the person can affirm and assert their identity, but identity does not develop in a vacuum. Yeah? Identity develops in relation to others. So basically, if you are in a relationship with people who are constraining you, it's possible that, you know, you feel differently than if you are in a household, for example, that accept all gender from start. So it's possible that basically you are identifying as trans, but you don't understand it that way because you don't have the constraint around you to kind of put you in that box. Does it make sense? So we really need to understand that there's so many ways of experiencing that as a young person, okay? And it can take really different pathways to realization and affirmation. So what are their experience? So we know that trans youth experience poorer health outcome than the cisgender young people. Okay, so this is clear. As I said, we need to be careful because some young people will be in situations which are worse than others. But if we look like generally speaking, they experience like difficulties that cisgender counterpart don't experience. And I would say so that they are vulnerabilized. They are not vulnerable. They are vulnerabilized. Is it all right in English? Is it the right word? Yeah, they are vulnerabilized. Yeah, because of the context around them. Okay, so depending on the context around them, they might experience a higher rate of all of those things. Suicide is a big difficulty that lots of young people will face. In the Transpulse research coming from Ontario a couple of years, well, a little bit more than a couple of years ago now, they realized that 77% of their sample had suicidal thoughts. So that is a really high rate. And then out of that, there's 43% who committed suicide. And in that, if you look at that, the age of those young people, if I remember well, is about 78% of that 43% who did it before the age of 22. And then it's 36% of them who did their first attempt before the age of 15. Okay, so it is a very serious issue, suicide in the trans youth communities. They also experience depression, anxiety, eating disorder, more at risk of leaving school. Why? Because, you know, they experience victimization in school. And because, you know, for example, they can't use toilets. So, I mean, there's not many people who wants to go to school when you're not welcome in your environment. So you can see all of that. Again, the importance of going through an intersectional, you know, framework and lens. And of course, there's a lot of reject from parents and extended family. It's about roughly 1/3 of the youth who will experience some sort of good support by their parents. The rest will be like either rejected plainly, or they will experience what we call a form of negative neutrality. So it's not something really that they're not going to be told, well, you leave the house because you're trans, I don't want to see you. Some people experience that, obviously, but they will be like, the majority will be like in a situation where the parents won't kind of acknowledge, affirm the identity. They will tolerate them in the house. And this, in one of our research, it shows that it has like an as bad effect on their well-being than just being rejected, okay? But being trans is not a problem. We need to really understand that. As I said, they are vulnerabilized. So, you know, its difficulties are often emerge from the result of negative climate, transphobia, relational difficulties, parent friendship that kind of, get unstable when the young person is doing the coming out. And I wanted to put that citation from the World Professional Association of Transgender Health. If you don't know that organization, it's an organization made of researcher, clinician, trans people. So it's really an organization working with a range of perspectives. So it's not just one perspective on the experience of trans people. And they came in 2011 already as the expression of gender characteristic, including identities, are not stereotypically associated with one assigned sex at birth, is a common and culturally diverse human phenomenon that should not be judged as inherently pathological or negative. Okay? So a lot of the difficulty experienced by young people come from the outside. social environment, but there's also some young people who experience difficulty that are coming a little bit more from the inside, okay? And we can't just kind of brush that down. It's really important that we understand. So there's some young people who will experience the, what we call gender dysphoria. Gender dysphoria is a diagnostic, is an official diagnostic from the DSM, but I think it characterizes well what some of the young people have expressed, so that's why I'm using that again here. But it can describe the distress experienced by some trans people due to an incongruence between their gender identity and their sex assigned at birth. So it's like when you feel like, oh my gosh, you know, this is not what I feel I should be. You know, there's things that bothers me. And it can cause like great distress. And what we see is that in young people, gender dysphoria can occur when they're very young. So we see like 3 years old, 4 years old already saying, this does not belong to me. When is that going to fall off? Yeah, so it's something real for very young people. But what we see is that when they hit puberty, that often is going to be a really big trigger. Because imagine in your own gender identity, current gender identity, and you start having sexual characteristic of a gender identity you don't identify with. I mean, it is like very traumatizing. I could have put like so many more citations from our research, but I just put that one from a trans-masculine young person of 23 years old to say that dysphoria put me in a phase where I'm very uncomfortable with my body and I don't feel good about myself. So it's got like real consequence on the young person's well-being. So what do we do to improve the well-being and decrease the distress? So we must remember that this distress caused by social environment and this distress that may be caused by, you know, individual kind of characteristic that the person don't feel comfortable with. There's 3 types of what we call a transition. And we must understand that these are not in special order. So I've put social, legal, and medical, but you can start by medical, legal, you can do a bit of medical, go back to social, you can do whatever you want, yeah? There's no start, there's no end. So again, it's about understanding then it's the person who are experiencing it that can decide what's right for them. But I'm going to explain a little bit what they can involve. So when we talk about a social transition, this is often what is the only permitted transition when you're very young. So under puberty, you can't do really much more. Well, you can do legal, I'll come to that in a minute, but it's really the first one that young people will do, children. So it's about kind of changing your appearance so that it matches with your gender identity. And it's also often about changing your name and changing your pronoun. So that's about, you know, using the pronoun you feel the most comfortable, either she, he, they, elle in French, or whatever feels comfortable for you. And it's having, yeah, so, and this we see that it's really important. I mean, I've put like a couple of research here, one that is very recent that show that having their name and pronoun respected, what it does is that it really lowers depression and suicidal behavior in young people. So you can see that just by allowing a social transition and following the child and really kind of making sure you respect what they're asking for, you're already decreasing the odds of that child, you know, feeling bad about themselves. So it's really, really important. And the other one is, this is a really, really important piece of research that's been done at Washington University by Christina Olsen and her team. But she is following for a long time a cohort of young people, of trans children, who were allowed to socially transition in their house and were affirmed by their parents. And so she's been following them longitudinally. And what she's found is that those kids who are affirmed by their parents, she's got like young people who are trans and she's got young people who are cis in her, so she can compare. And so what she's realized is that basically young people who were allowed to transition and are affirmed by their parents, they've got the same mental health outcome than cisgender peer. Okay, so they're not worse off. The only place where there's like a tiny slight difference is that they are marginally more anxious. And this can be explained by the fact that maybe they are affirmed in their family, but when they come out, it's possible that they still experience those transphobic, you know, that I was talking about. But so you see, just those 2 pieces of research from secondary sources, how it's really, really showing you how it's important to respect and kind of follow the child's lead. That's where we're going to get into a message, but the evidence shows us that it really helps in terms of well-being. Then there's some young people who will decide to move through legal transition. Legal transition involves basically to be able to change your name and gender marker on birth certificate. And what does that is that after that you can change your code permanent, at school, and you can change your Medicare card, and you can change everything else with that. So that's what we call a legal transition. Before 2016, it was not possible for minor to do legal transition, and before 2013, but regulation came into force in 2015, adults needed to have full sterilization to be able to change their gender marker on birth certificate. So this has been a lots of gain in a very short time, but I just want to stress that young people could not do that before 3 years ago. And still now, not every young people can do that. And I really want to stress that, because even though it was a really good gain, there's still work to do, because to be able to change your gender marker on birth certificate, you need to be a Canadian citizen, and you need to be resident of Quebec. And you need to fancy to identify either as a female or a male. So if you don't identify as either, you can't change it for anything else. So we're still stuck in a kind of a binary system here. Okay, I'm going to move on quickly because I'm going to lack of time. Okay, so basically legal transition means we can change gender, because I've got lots of things to talk about. Medical transition, it's another type of transition when young people will use medication or surgery to align more closely their gender identity to their body. So there's grossly 3 types. First of all, there's the blocker, which is the medication that will put a pause on puberty. So it's going to stop puberty. So it stops all production of hormone. Okay, so what we do with that is normally we'll give it when the young person is starting puberty, so that it can buy a little bit of time, and it can also reduce distress, as we'll see in a minute from the research data. But basically, puberty blockers, it's that. Then after a few months to a few years, young people can move on to another type, which is going to take hormones to the hormones of their affirmed gender to be able to experience their real gender. And so that can be estrogen or testosterone. And then later on, they might or may not, because not everyone decides to go for surgeries, they might or may not go for surgery. So these are what we call the medical transition. Again, some people will want them all. Some people will want some people will not want some. Actually, one of my colleagues is doing a super piece of research on doctors prescribing hormones to non-binary youth and how young people, want things, and there's no protocol yet in terms of medication to be able to provide it. So that's really interesting piece of work. More to follow on that. But yeah, so young people might want, full blockers, full hormones, or some might want, again, it's important to follow their lead in a safe guideline, obviously, because when you talk about medication, it's not just about taking whatever feels you want to take. And what we see is that it really improves the well-being of those young people when they've got access, quick access. In fact, I've not cited that research, but young people are really at one of the most vulnerable points in their life between the moment where they feel they need to access the service and the moment they get it. So it's really important to kind of bring, service up to speed. And what I like about that last piece of study is that that's a study in Amsterdam, but I think it's very helpful because we don't have so much longitudinal study on those young people who are accessing hormones. And so they've done a long-term research with those young people, and out of their cohort of 70 youth who started blockers and hormone, 100% of them carry on with their transition, whatever their transition was. Okay, so it just showed that it's kind of quite safe, and it helped the young person to pursue. So this is not from my research, it's from my colleagues, Greta Bauer, Margaret Larson, and al. From another piece of research. But basically, the Trans Youth Can is a research where we're trying to look at well-being of young people who are accessing medication in 10 clinics across Canada. And so before proposing that research, we wanted to kind of take the pulse about, what's the referral rate. And so this is the referral rate. So we see that more and more young people want to access those clinics. Okay, so it's amazing. this is great because that means that young people know about those clinics. And I'll come back to that in a minute, because it doesn't mean that because they access the clinic that everyone can access the clinic. Because in fact, another study shows us that 61% of young people are unable to access any form of, medical health. Okay? So you see what I'm trying to show you here? I'm trying to show you both sides of the medal here. Is that there's young people who manage to access those clinics, but there's a lot of them who are not able to either. Okay? So we need to really think about those young people. And so it's important that those young people can access medical care a little bit more easily, because obtaining health care and social and psychological care is really linked to increasing well-being again. But I'm sure I'm not presenting you anything that surprises you here, yeah? Being able to access care, it's important for everyone, yeah? Okay. I'm just saying. Okay. Quickly, main professional association, what they say about care of young people, because when we think about ethics, I think it's important to look at guidelines and things like that. So several organizations oppose conversion therapy. I invite you strongly to go to see the site of Florence Ashley, who has kind of really compiled all the organizations that are opposing to conversion therapy or affirming the identity of young people. Florence is a young scholar in bioethics at McGill. And, closer to us, like there's, the Canadian Pediatric Society that came out with a statement last year saying that there's nothing medically or psychologically wrong with the child. Gender identity, gender diversity is not the result of an illness or parenting style. I think it was important to say that because, as an aside, for a long, long time, people thought that trans kids were trans because they had bad attachment with their mother. So, yeah. So it's nice that the Pediatrics Society now came with a statement on that. And closer to us, we've got the Ordre des Travailleurs Sociaux et Thérapeutes Conjugaux et Familiaux du Québec, who have really asserted that trying to change someone's identity is unethical and an abuse of power. So we've got like some organization that will really kind of provide some strong statement about how to intervene with kids, and some others that will provide kind of less strong statement, but nevertheless will say you can't do conversion therapy with them. So that's a little bit what we have in terms of like landscape of professional organization. So what current research tells us about the experience of those children who access those clinics? So how do they do, those children who access those clinics? I would say that before our research, there were very little data on that, especially qualitative data. So sometimes we'll get statistic, as I told you, they access clinic, but we don't know what they experience. And what we had as research, we found one research that looked at kids who were accessing gender clinics, not gender affirming clinic, just gender clinic to get like some sort of like treatment. And what they found is that they experienced delayed, limited access to train gender affirming healthcare provider, that there were inconsistent protocol application, and that basically they were misgendered in the clinic. So this is not a really good experience. Because I told you, it's really important to respect the young person's name and pronoun if we want to improve their well-being. So imagine you go to a clinic and then you're not respected in that clinic for who you are. So it causes lots of problems. So we wanted to know, okay, in Canada we're lucky. We've got like 10 plus clinics who are gender affirming. So what's the experience of the kids who are going to those clinics? So that's what we're going to look. So just to show that this is not just my research, it's a research where many people working on that. And it's a project that I'm going to talk about now that is funded by the CIHR. Very briefly, the methodology, so you understand what I've done. So we started by a grounded theory methodology that we slowly adapted into a hybrid model, combining grounded theory and thematic analysis, because it was very difficult to kind of apply that protocol in different clinics. Going through ethics clearance in different clinics requires lots of adjustments, so we had to adjust a little bit the methodology about that. We used the social determinant of health as a framework for a sensitizing concept, so we didn't want to just kind of bring the data into that, just kind of be guided by that. We collected data at Meraki Health Centre in Montreal, at the Children's Hospital of Eastern Ontario, and at the Health Centre Science in Winnipeg. Okay, so these are our 3 clinics. And why we say that they are gender-affirming clinic is that while they differ in terms of staff, resources, and a bit of the protocol, if we look at protocol, there's places they will give the blocker a little bit later than, So it's not everyone use the same protocol, but they are all committed in respecting the young person inside the clinic. They've got like gender-neutral spaces. They use right name, pronoun. They've got the form that are adapted. So you won't get that sort of experience of those young people who are trying to access services in other clinics that are not gender affirming. So we wanted to know how it happened. And what we did is that we did 70 semi-structured interviews with 35 child parents diet. That's another thing that is really interesting in our project, because we didn't do research with parents and then research with kids. We talked to the kid and then we talked to their parent. Not to compare and contrast what they're saying, but to have like a better kind of deeper understanding of what's going on in terms of family dynamics. So I can't tell you too much about that family dynamics because we're still analyzing data, but today I'm going to focus on those 35 children who talked to us about their experience. And we used MaxQDA to analyze data. I don't know if you know that, but it's really good. It's a good software. I'm just saying like that because I think sometimes people who do qualitative analysis, there's always issue with all the software, so that's a good one I found. There you go. So who are our participants? So they are between 9 and 17. As you can see, we've got more transmasculine than transfeminine participants. It was more difficult to recruit transfeminine participants. And we've got 3 transmasculine participants who identify themselves as non-binary. So they're more transmasculine, but they say, well, I'm somewhere in between. I'm floating around, yeah? We did some interview in French and in English. There's half of them about to change their legal name, so you've got half that didn't. So that's interesting because you'll see later that they were still respected in their identity, which is great, because when you've got the medical card, sometimes it causes problem. And the majority were white youth. And for those who, I don't know if there's people who were at the lecture by Jake Pine last week, but Jake Pine was talking in Montreal last week in a public lecture, and he was saying that there's problem in young people, culturally diverse young people accessing those clinics. And actually we did so much effort to try to recruit young people, other non-white young people, and we weren't able to do much. And those young people who are Asian or indigenous, they were adopted by white families. So again, it shows, there's an issue in getting access to those clinics. So I just want to mention it, coming back to the importance of looking intersectionally at that data. And so there's some who were covered by private insurance, and you see the household income tended to be higher, toward higher values. So the young people who have a little bit more mean to be accessing those clinics. So I'm not going to talk about all the data. I'm going to focus on how they feel about the medication that they took. So when we look at the overall medical intervention, among those who started those medical intervention, because you remember we've got 9 years old, 10 years old, 11 years old, so there's some who are at the clinic but don't access anything, because for having puberty blockers, you need to be at least at Tanner stage 2 of puberty. So you need to have started your puberty. So if you've not started your puberty, you won't have blockers because you don't need blockers, because blockers block the hormones. So you see what I mean? So it's not about stopping the kids having a medication because you're a gatekeeper. It's really about the kid not needing it, okay? So those who have started medical intervention, they felt very positive about the intervention they had received. So that's really a good thing to say. And they improved their outlook on future and well-being. Okay, so I'll come into a little bit more detail per blockers, hormone, surgery in a minute. But if we look at the overall data, we can see that overall, it really looks like it's helping them a lot. And those who had suicidal thought or had engaged in self-harm, which is not at all the same thing, but it's two things that are kind of quite serious for those young people, it has decreased their thought just to have access to those medications. So it's a good start in terms of outcome. So if we look quickly at puberty blockers, so young people wanted to take the blocker because they wanted to stop puberty, and basically it alleviated their experience of dysphoria by stopping the puberty. So those young people who were in distress because their body was changing, because they just hit puberty, to have the blockers had a really positive impact for them because they felt like that puberty was blocked. And this was whether or not they saw actual physical outcome. Okay, so there's young people who you're like, oh, I'm not too sure what I'm seeing yet, but just to know that I am that, I feel great because I know that it's not going to carry on without me wanting it to carry on. Yeah, so it's really, really important. And yeah, so it represented a step forward, the transition. And overwhelmingly, accessing blocker was described as providing a sense of relief, great optimism, sorry, positive impacting their mental health of participants. And I've put a citation here from Tia, who say that mental health-wise, in the sense that I can stop asking myself about those questions, you know, what's going to happen with my body? I won't be worried anymore about how my body is going to change. So you see, just blocker, it's a really big relief for those young people who participated in our study. And I'm going to talk about limitation in a minute, but you know, those who participated, they thought it was really important for them. Here we go. Hormone therapy. Again, they spoke about their effect positively. Made them happier, less anxious, less dysphoric. So this is the step where they were on blockers for a little while, and then started taking either testosterone or estrogen. And basically, you see that from Joseph, who said that self-harm was a thing that was happening for a long time. And since grade 2 or 3, and he was really unhappy, and it's better now that I'm on testosterone because I'm kind of feeling like content, like things are going to get better. So you can really see that in the citation of that young people, how just having access to that hormone is having a positive impact on so many spheres of their life. Yeah. Trans-feminine youth, what they wanted and what they had, what they noticed the most was fat redistribution. They noticed like softer skin, and but most tended to describe those changes very slight or slow, almost invisible. So they wanted to have more quickly, but it takes time for that to work. But you know, these are the two, you know, fat redistribution and softer skin, that the two most kind of common positive physical side effect that they saw. And trans-masculine youth, in terms of visible effect, that was a little bit faster. So they saw change in their voice, getting lower, facial and body hair grow, and in several cases, the changing shape of their face, neck, and shoulder. So you can see how, if your body is starting to align more at your gender identity, how it can bring that sense of well-being and release I was talking about. So these made them feel like they were being read also more as males. So that was I mean, I don't have time to go very much into detail, but young people were telling us, you know, taking hormones is helping me not only because of the way I perceive myself, but also because of the way people perceive myself. So we were talking about gender dysphoria earlier, but there's also what we call the social dysphoria. Social dysphoria is the experience of going into different spheres of your life and being misgendered, being called by wrong name, wrong pronoun. So young people who were starting hormone were telling us, this is really important for me as well, because it alleviates, they didn't use that word, but it alleviates that social dysphoria, because I'm read more like my gender identity. So it was very helpful. And surgery, my modest and equal one. You understand, I'm working with youth. Yeah, I'm working with minors, so they don't have surgery. Minors, they can't have surgery. They can't have gender-affirming surgery in terms of like bottom surgery, so it's not allowed. But one of those young people had the mastectomy. And so we were really interested to know, how is it? And basically, it was great, because he told us that it was the most, I want to use his word, the biggest difference in the whole thing was this top surgery. So again, overwhelmingly, I would say that young people felt that, you know, well, that young person who had surgery felt that it was really improving their well-being. Okay. However, there are some also negative effects, and you know, we need to talk about that. It's not all rosy, although it's very, very positive overall. There's some young people who talked about, you know, negative side effect, because the side effect that they want is what the body does, but sometimes there's like other negative side effect. So in terms of blockers, a lot of them talked about hot flashes and mood swing. it was not so much of a problem, I would say. They kind of navigated that well, but you understand if you start having hormones and then you take a blocker, it stops the hormones. So it can put you in some sort of menopause, yeah, or it stopped basically your hormone. So that was a problem. And there's one young person who said, well, when I started blocker, I had a suicide attempt, okay? But he was telling us also, and I think that's why I want to really stress, he was telling us when I got to the clinic, I was in a really bad place. I was not well. I was, so he's not linking it to taking the blockers, but for him, there was something about mood swing. So that young person was like, yeah, he said, that's his word, he was in a very dark place, and he had already had a lots of difficulty. So we can't, you understand here, I'm not doing any way correlation because I'm working in qualitative, but I think it's important that, I voice the young people. And there's another, side effect that was said that is probably related to the blocker is the stress fracture. Because if you stop the hormone too long, what it can do is that it can affect your bone density. And so, again, it's not, we can't say that it's 100% sure it's that, but one of the young person experienced that during that. But they also said that they were feeling, even those who had the most serious side effect, all said that they would still carry on with what they were doing, if it makes sense. We also asked them about second thought or regret. So every young people, we ask them, so, do you have any regret about what you're doing? Would you feel comfortable to stop? Because this is something sometimes we hear. People are worried that young people just get into something and can't get out. So we've asked them, how do you feel? Do you feel you can get out, you can stop? And so none of them express regret. And what's interesting is that a lot of them express questioning, which is very healthy. And again, it shows that those young people are able to make the decision and able to reflect on their own life and identity. But, you see here one Brandon who say, I had little moment where like, what am I doing? This is something serious. But then I look in the mirror and listen to my deeper voice, and it's like, this is what I want to do. Okay, so you've got young people who were questioning it, but then by the effect, they were really happy. And then another one, Stephanie here, will say that she's never regretted ever since. Honestly, I don't really know how I was a boy before, because like it must have been really unhappy, because I'm super happy like being a girl and just like being a girl. So it really has very good effect on children. And so overall, those medical interventions appear to be very positive, even for those who had those secondary effects. And this is Jason, pseudonym obviously, Jason, who I was talking about, that young person who was in a dark place and had a suicide attempt, says my life was magically better after taking hormone. I was like still in the same person. It's just that I had more drive to study, more drive to pay attention in class. I wouldn't be plagued like, oh my gosh, I just want to die. So you see, again, even for that young person who had, a difficult start, still kind of felt like it was really important for him. So the overall experience at the clinic, I would say that they felt that there were too longer waiting time. And I said I was not going to talk about the parents, but we know that these young people takes time to get to those clinics. I've not talked about it, but they told us, the young people, that the first step is to tell their parents. Because when they're young, they can't access those clinics. So just that time to figure out for themselves, then the time to find, the strength to tell their parents, the fear, to fight that fear of telling their parents, and then you've got like a really long time. And then you need a referral. So you see, by the time they come to the clinic, it's been a really, really long time. So for them, it was like too long. Waiting time was too long. They needed that faster. And that they felt also that some delay was unnecessarily long. So you've got like a citation here saying that. Other concern was having to return to the clinic often, because young people who take blockers, who take hormones, obviously they need to have blood tests to make sure everything is fine in terms of like other function of their body. And I just want to voice some non-binary participants as well, who said that they felt that they were limited in terms of medical treatment, because the protocol say, well, if you want to transition to male, you do this. If you want to transition to female, you do that. But there's young people who didn't identify as male or female, so they felt that basically the protocol were not adjusted to them, and that was difficult. Yeah. So you see one here who say blockers, it's a maximum of 2 years for the reason I was mentioning about the bone. So you can't take that without hormones for a long time. So after 2 years, that young person was saying, I need to take something else, but then what? How am I going to do that? So I have to choose if I want to go on estrogen or on testosterone, and that, again, where I'm feeling more in the middle. I don't want to choose one. I just want to stay in my body, which is not completely done. It's stuck. Again, scientifically, even though there's no much I can do, it's probably just going to get old and maybe get some surgery, a kind. So you see that young person is like still kind of figuring out, where they feel in terms of like on the spectrum, but the protocol kind of, bring young people often to go onto one or the other. So that was something that we need to reflect on. So what do we take from this study? Obviously, I didn't go too much into detail, but I would say that accessing gender-affirming healthcare emerged as positive experience for young people. Frustration more frequently invoked by youth concerned delay in accessing the gender-affirming care. Protocols sometimes appear to be too restrictive, especially for older and non-binary participants. We also take from the study their ability for critical reflection, to identify and assert their need. I think it's really important because it's one of the first studies that look at how you're dealing and managing that, and we see that they're so very aware and critical, and they say, this is what I need. They know what they need. They've delineated also the substantial benefit from what they want to the side effect that they don't want, and they're able to make decisions on that basis. They emphasize how important it is for specialty clinic to maintain gender-affirming care. It also highlights a need for intervention plan to be more flexible and used more creatively. As I was saying, my colleague was doing that research on non-binary patient. Maybe it's going to help kind of answer some of that. And it reinforced the assertion that the provision of gender-affirming care in clinic remain highly relevant. So, quickly, my study limitation is a small n. They are self-selected participants, so obviously they had things to talk about. They wanted to talk to us, so those who didn't come to the study, maybe they would say a different story. The sample is not very diverse, and the study design and recruitment document were such that only the young people with the parent could participate. So you don't have those young people who didn't have that good support were in there, so we need to really kind of reflect on that. And the sample of prepubescent youth is small, so we're not able to see so much what's the experience of the young people who's not started blockers yet, because we had just 4. Yeah. So considering, and I've got 10 minutes, a bit quick, isn't it? So considering previously published evidence, I think, policy orientation, current emerging data on trans youth experience. And if we look at the principle and ethical framework, and now I'm not going to push one on you because I don't know what discipline you're from, what you're doing, but if we group them, I mean, you've got like the line of autonomy, self-determination, respect for the person, recognition. Yeah, I think that's one great box. I think if we look at that, well, we need to come back to only the youth can affirm and define their identity, and the evidence show that they can do that. Yeah? The start of evidence. If we look at beneficence, evidence show that young people benefit from gender-affirming intervention. I've not seen evidence yet of young people who did not benefit from that sort of intervention. The non-maleficence, they are considered safe. It's not experimental things, these drugs have been used for other medical need. It's sure that we need more research. I think we need more research. We don't have like 40, 50 years of longitudinal study. But then when you think about it, those young people have an immediate well-being effect. So we need to take that into consideration, don't we? Even if we don't know what's going to happen in 40 years, if we know that it decreased the suicide rate right now, I think it's still something to take really seriously into consideration. And we've got the issue of justice. For me, there's question of access, that is emerging from that. So I think if we look at what our responsibility with regard to the care of trans youth, I mean, I don't know how it works, those seminars. Normally you just talk, or I know we're live on, I don't know if there's people who wants to express themselves on that, or before I go to my last slide. No? No thought? Comment? Question? Complain? No? Okay, well, I think for me, of course I'm working in that area, and I'm looking at that evidence, and we're talking to young people, and I'm involved in also in intervention with those young people. Because we know that the expression of gender identities that are not stereotypically associated with sex are part of human diversity, because we know that the evidence show that there's benefit into those interventions, and because we know that many problems experienced by trans youth are rooted in negative climate and transphobia, and because barrier to access continue to be a big issue, I would say that probably what's our responsibility is to educate oneself about trans youth as a society. We need to all educate ourselves about the existence of trans youth and about the fact that they are everywhere in different cultures, and that there's always been there, that it's not something new. So people have got that. I think we've got a social responsibility to educate ourselves. Oof, big typo. I think professionals should increase their access to services by training themselves. I think not just like specialist clinic like Meraki. I think, every GPs, general practitioners, nurses, professionals who might interact with trans youth, i.e. everyone, because they're youth. So everyone who works with youth should educate themselves and train themselves so that we can increase that access, so that the young person does not get into like the entry of a CLSC and get misgendered because they don't have ID that don't match with their identity. I think the state should invest more fund to increase the access of service. Obviously, I'm thinking about that principle of justice here, because there's no justice in terms of like access to legal transition, because there's a lot of people who can't do it. There's no full justice in terms of like access to service, because those services are mainly located in cities. There's no justice to access either, because they're mainly white people accessing those clinics. So we need to make sure that there's like a greater access in every single ways, not just fast access to one clinic. And I think we need to continue with research to produce more evidence to support trans youth better, but we need to put a greater attention to centering the voice of those young people in those research. So it's not about doing research at any cost, because trans people have been already over-researched, and often it's research that are not it's not situated in an anti-oppressive framework, and it's research that can be dehumanizing. And so I think it's more research, but more good research. We need to make sure we involve young people in the research as projector of knowledge themselves. So I think that's my conclusion. Thank you.
All right, so maybe if people were a bit shy 2 minutes ago, maybe now there are some questions. Does anybody, or just comments or thoughts? We're going to be using the microphone just because it's live streamed so that people can hear. Would anybody like to say anything? Yes?
Thanks. Hi, I just had a question about what you mentioned a few slides back, that in terms of like drawbacks, I guess, that non-binary folks and older trans youth feel more restricted in these clinics. Why exactly do older trans youth feel more restrictions?
Yeah, because this was a question of protocols in some clinic, where when you hit stage 4 Tanner, they don't give blocker anymore,
Okay.
And so that was causing a little bit of distress to some young people who felt that they were limited in terms of like being able to access what they felt they needed. So that's why, the older folks felt that they needed a bit more flexibility. I mean, I suppose the rationale is that if you don't, blockers is to stop puberty. So if you're already kind of gone through puberty, there's no point taking blockers. Same for a young person of 9 years old who want blockers. If they didn't start the puberty, there's no point taking the blockers. So, I think it's about, for me, knowing that data, it's about perhaps having professionals engage in a more proactive and open manner with young people and saying, look, you don't need blockers. And I explain you why. If you need something else, we'll find the right thing for you. But as a medical professional, I can tell you this is not the right medication for you. And maybe it's been done, maybe it's not been done. So this I can't verify. But I can tell you that this was a concern raised by some older people. And so perhaps a way forward is to make sure we increase that communication so that there's no misunderstanding. Because if you understand why you can't have it, or that it's not a question, because sometimes you can have question of like not having access to medicine because of gatekeeping. Yeah? And sometimes it's not because of gatekeeping. Do you understand? So it's about delineating what's gatekeeping and what's not good for you, or what's not going to be helpful for you. And so maybe this is like something important to do, and that come back to the question of informed consent, about being able to decide. I don't know if you answer your question.
Yeah, thank you.
Okay, merci. I had a question about, so you've been talking a lot about gender-affirming medical care, and I was wondering, I had two questions. My first question, so because your study involved parents, I had a question about barriers to access. So question one, do youth need parental support or a certain type of environment of support to enter into gender-affirming care? Is that a restriction?
It depends on the province. So these are provincial laws in terms of access to care.
Okay.
So if I'm talking about Quebec, from 14 years old, the young person can access all those services without the parent.
Okay.
So, but some provinces it's going to be older, and it depends. Like in Winnipeg, parents had to consent for the youth to take part in the research up to the age of 18. So it depends on where we are. So it changed from one province to another.
Okay.
But it's normally the access to care is it's a law. It's yeah.
Okay, thank you. And my second question is about, I was wondering how some of these clinics are structured in terms of, so we've been talking more about certain aspects of medical care, but in terms of whether these clinics also include, I guess, what we could call like gender-affirming mental health care, and so how that's negotiated within the clinics, or if those things are separate, and what are some of, I could imagine issues accessing gender-affirming mental health care and not being pathologized in their experiences. So,
well, we have more data from the parents interview, because they are those who were telling us, well, I needed to access mental health and I didn't have any insurance, I couldn't access it. And so there seems to be like a lot of health inequalities popping up in terms of like mental health. So medical care is universally covered except for the medication. So that's another problem, because there's some medication that costs more money. But mental health, it depends again on the province. It was an issue, though some clinics had better service than some others. So I'm not going to name the clinics here, but there's a clinic, for example, that had a social worker, that had, that had some mental health professional, whether some other clinic didn't have free of access. So they had some professional trained around the clinic, but they needed to pay for it.
okay.
Yeah.
Thank you. Anyone else? Any thoughts? Yes.
Hi. I just have a quick question around strategies for recruiting a more diverse sample. So I'm just curious to hear about how you tried to tap into different populations, and how that experience might inform future strategies for you.
Yeah, this is really an issue because of the size of our population, because there are kids who are in clinics already, so already we're limited with that. And then we must make sure, because they are receiving care there, you need to make sure that they're not feeling obliged to do the research. It's very dangerous to slip that way, you know, if your doctor is doing a piece of research and you feel that it's going to affect your care. So basically we had to go through a lot of thought about how we're going to recruit, and the way we felt was the most appropriate was to send letter of invitation to subsection of that population, you know. So we're trying to select prepubert, pubert, you know, transmasculine, transfeminine, you know, different kind of backgrounds. And then we sent letters of invitation, and they had to contact us to say they wanted to participate, but not the doctors. They had to contact a research assistant. So it was kind of, you know, we were making sure that the patient, that the doctor would not know that the patient participate, you know. So you see, so we sent a lot of letters to people we wanted to recruit, but then the person needs to come back to us saying, I want to participate. So it's very difficult to, so then we send more letters to people we wanted to participate, but if they don't come back to us, then it's difficult. So this is, I think that's the beauty of working in clinical care. When we do research, like we've got another project here with lots of like community partner in Montreal, which is looking at trans youth experience, not just those coming to clinics. And that one, I think we're having much more, you know, we've managed to recruit, you know, 5 Indigenous youth in our sample, so which is quite good, you know, out of 50 interviews. It's not a too bad percentage. We managed to get like a lot of migrant youth. So, but because this is like community partner can approach the young person saying, look, you know, we don't have any interest in that. If you want, go. It's important. Da da da. So it's easier to go to recruit a more diverse sample than in clinics where you really need to follow strict protocol to make sure that the young person don't feel constrained in participating.
Thanks.
I've heard testimonies from a couple trans people. I don't know exactly what province they're living in, but in Canada, where they talked about having to prove the existence of like gender dysphoria in order to access services. Was that the case for these clinics? Is that generally the case, or how does that work?
Well, those clinics, because they are gender affirming, it wouldn't make sense to get the kids to prove, you know, that, because proving, I mean, how do you prove?
Yeah, it's like another accessibility issue.
You know, it's not something, but, you know, there are some young people, despite that felt that they weren't sure if they were going to be able to have access to those medicine. You know, they felt like, am I going to be able to? So I don't know if that count as maybe feeling that they needed to prove, but from the protocol, they don't need to prove. I mean, it's sure that the young person needs to experience gender dysphoria, because you don't get medication if you don't, you know, if it's social dysphoria, there might be something else. I don't know. Do you know what I mean? Again, I'm not a doctor, so I don't prescribe, but young people don't have to prove that they are trans, but they need to experience some gender dysphoria, I would say. Yeah.
Thank you.
I think I hope it's kind of clearer. Thank you. Thank you.